Hi everyone, my name is Rui Bergantim. I'm a hematologist in Hospital São João in Porto, Portugal, and I'm also a member of the direction board of the Portuguese Multiple Myeloma Group, together with Cristina João from Fundação Champalimau in Lisbon and Catarina Geraldes from Hospital of Universitário de Coimbra in Coimbra. Recently, our group published the first national guidelines for the treatment of multiple myeloma. We know that the treatment of multiple myeloma has changed a lot in the last few years with the use and combinations of several new drugs that were developed recently. Of course, most of the countries around the world have different policies of reimbursement and approvals. We know that several international interest groups in multiple myeloma have published recommendations that may vary in their application in clinical practice, mainly because of these different and policies and drug reimbursement activities. Our guidelines tries to cover the various stages of the treatment of multiple myeloma, taking in account the specificity of Portugal, mainly in approved and reimbursed drugs or protocols. We also try to do and to publish these guidelines in order to uniform the treatment of multiple myeloma along several hospitals in Portugal that treat this disease, not only in the public but also in the private practice. A key highlight in the first line of our guidelines is our emphasis in the use of daratumumab in association with VTD or VRD in patients eligible for transplant and DRD in non-eligible patients. Our recommendations are in line with the results from several trials showing the superiority and advantages of including daratumumab in the first line of treatment. Of course, despite the changes in the approach of the first line of multiple myeloma treatment with inclusion of more effective and less toxic therapeutic regimens, high-dose melphalan followed by transplant, autologous transplant, remains the gold standard, and we recommended it in all patients that are eligible for that. We are also recommending a tandem transplant in patients with high-risk cytogenetics. Regarding treatment of maintenance, our country has approved lenalidomide till relapse or toxicity, and for high-risk patients, there is already evidence for the advantages of combining lenalidomide and proteasome inhibitors such as bortezomib. Regarding relapse setting, decisions and options are more difficult to make. Our option will vary mainly if the patient is previously exposed to lenalidomide and daratumumab. And right now, almost all patients are already exposed to lenalidomide. The proposed treatment after the first relapse should enable the rescue of massive number of patients. And of course, we should be carefully choosing these protocols among the available options, given the clonal heterogeneity and also resistance process that occur during treatments. We have to optimize the second line of treatment and choose our options, taking into account different groups of drugs from different therapeutic classes, comparing the previous ones. And of course, we should consider the patient's frailty, comorbidities, and any toxicities that they may have existed with previous treatments. Of course, this is even more challenging and difficult when we speak about 2 or more lines of treatment. Right now, most of our patients that are in third or further line already been exposed to 2 or more proteasome inhibitors, 2 or more immunomodulators, and more than 1 anti-CD38 monoclonal antibodies. These patients have poor prognosis and a dismal survival. We try to include these patients as possible in a clinical trial, but most of our hospitals don't have clinical trials open, and it's very difficult to treat these patients. For patients who are triple or penta-refractory, therapeutic options are scarce, and we are trying to use, and we recommend use, new agents with new mechanisms of action, mainly bispecific agents right now. Of course, CAR T cells in countries that will have access or already have access to that should be used in this phase. Our recommendations offer key guidelines for a country in the treatment of multiple myeloma, not only first line, but also in progression and relapse setting. Of course, first line in the treatment of relapse in third or further lines are the more challenging. Of course, it's important to optimize these options and combining the right drugs, the right protocols in the right time, and of course, with the correct characterization of the patients, not only functional robustness, but also comorbidities will allow us to minimize toxicity, increase survival, and improve quality of life of multiple myeloma patients.